Welcome, everyone. Thank you for joining us for the webcast, Emerging Trends, What Employers Need to Know About Alternative Funding Programs and Drug Carve-outs, sponsored by Aimed Alliance. This webcast has been pre-approved for HRCI and SHRM credit. Please be sure to attend the complete webcast in order to receive your credits. You will receive an email from hr.com within 2 business days. It will include the certification credit information. You may also log into your account and view the credits that you have received. If you have any questions during the webcast, click on Q&A in your webinar controls and type them in. And now it's my pleasure to turn it over to Ashira Vantries.
Thank you so much. Good morning or good afternoon, everyone. My name is Ashira Vantries and I'm counsel at Aimed Alliance. If you're not familiar with Aimed Alliance, we're a nonprofit health policy organization whose mission is to protect and enhance the rights of healthcare consumers and providers. I'm thrilled to host today's webinar with the Alliance for Patient Access. The Alliance for Patient Access is a health policy organization that advocates for prioritizing patient-centered care, supporting clinical decision-making, and acknowledging each person's individual healthcare needs deserve to be met. Today's webinar is going to discuss some of the preliminary findings of a survey that Aimed Alliance and the Alliance for Patient Access conducted on hr.com on employer trends and perspectives on prescription drug coverage. So with that, I'm pleased to turn it over to Gavin with the Alliance for Patient Access.
Thanks, Ashira. Welcome, everybody. We're really excited to have the opportunity to work on this project and help educate employers about the various tactics being implemented to help employers save costs, but also the impact that some of these policies may have on their workforce. Before we get into the survey, I wanted to do a brief overview of the Alliance for Patient Access. As you can see from this slide, AfPA focuses on three principal policies of patient-centered care: access, value, and the physician-patient relationship. Made up of healthcare providers, AfPA prioritizes patient-centered care and advocates for policies that support clinical decision-making, allowing patient access and acknowledging each person's individual needs. AfPA has 2 methods of advocacy: physician-led working groups and coalitions made up of patient advocacy organizations. These working groups and coalitions touch several different disease areas, but what they have in common are access issues, including alternative funding programs, the topic of today's webinar. AfPA educates and raises awareness of the harmful effects of one-size-fits-all insurance tactics on employees. These include tactics like prior authorization and copay accumulators, which delay needed care for patients. But today we are looking at the use of alternative funding programs. During today's webinar, we will discuss the 2023 survey findings on employer coverage trends. To help us better understand what some of these findings mean, we have invited 3 experts to participate in the discussion and give us some of the reactions to these survey findings. With that, I'd like to introduce today's experts. First, we have Cheryl Larson, who is the president and CEO of the nonprofit Midwest Business Group on Health, a coalition of more than 150 mid, large, and jumbo self-funded public and private companies representing more than 4 million covered lives. She oversees all coalition activities, including advocacy, membership, administration, research projects, and educational activities, working closely with MBGH's employer-led board of directors to establish the strategic direction of the coalition. Second, we have Kim Zubarek, who joins us. Kim is the Associate Vice President of Policy at Cancer Care. She's an attorney with expertise in health policy who uses her prior experience in civil litigation and disability law to help improve patient care, coverage, and outcomes. As Cancer Care's AVP of Policy, Kim oversees the direction of Cancer Care's advocacy efforts and advances the organization's national policy agenda. Kim brings 25 plus years of nonprofit experience and a commitment to driving meaningful patient-centered solutions. Kim earned her Juris Doctorate degree from George Washington University Law School and her Bachelor of Arts degree in Political Science from Union College. A bit about Cancer Care. Cancer Care is the leading national nonprofit organization that provides free professional support services and information to help people manage the practical, emotional, and financial challenges of a cancer diagnosis. Finally, we are joined by Amy Niles. Amy is the knowledgeable healthcare executive passionate about growing sustainable health organizations, advocating for patients, and building strategic partnerships to address public health needs. As the Patient Advocacy Network's Chief Advocacy and Engagement Officer, she leads the organization's relationships and partnerships with the patient advocacy and healthcare provider communities while overseeing public policy and advocacy initiatives. Thank you all for being here today and participating in the discussion. I want to turn it back to Ashira for a moment to talk about how we have seen employer health plans utilize alternative funding programs to replace insurance.
Thanks, Gavin. And like Gavin said, big thank you to all our panelists for being here today. We really appreciate you spending this time and sharing your knowledge with us. So today's conversation is really going to build upon a conversation that we started about a year ago when the AIMD Alliance and the Alliance for Patient Access hosted a webinar with HR.com on the impact of utilization management tactics like copay accumulators, prior authorization, step therapy on employees and how it can impact their ability to access their medications, which can ultimately impact them in the workplace through absenteeism and presenteeism challenges. So really today's conversation is going to be about how we've seen these utilization management programs evolve into what we now call alternative funding programs. So just kind of as a big picture overview, because we're going to get into the weeds a bit later in the webinar, is that alternative funding programs are third-party companies that work with employer-sponsored health plans to lower prescription drug spending. And the way they do that is by targeting specialty medications, which are essentially deemed high-cost medications for individuals with chronic conditions. And the reason they're targeting these specialty medications is because specialty drug spending constitutes about 51% of the pharmacy benefit spending. However, there's only about 2% of the population who are using these specialty medications. So obviously it's a high-cost item for a small amount of individuals. So employers have understandably been looking for ways to lower their spending in this area, and which has led them to turn to alternative funding programs. That's kind of the big picture, but we're going to hear from our panelists today about how these, cost-saving measures do have unintended consequences that can negatively impact employees. I'll turn it back over to you, Gavin.
Thank you, Shara. Before we jump into the survey findings, we wanted to go over some of the terms that we're going to be using throughout today's conversation. And so we wanted to provide some definitions as a level set for our conversation. So first, we're going to talk a lot about chronic disease. You'll hear about chronic disease. These are conditions that last 1 year or more and require ongoing medical attention. 6 in 10 Americans in the U.S. are impacted or affected by chronic disease, and it is the leading cause of disability and death in the U.S. Second, you already heard one time, but you'll hear it again, specialty drugs. So specialty medications are high-cost prescription medications used to treat complex chronic conditions like cancer, rheumatoid arthritis, hemophilia, and multiple sclerosis, among others. High cost can vary, so we want to note that, but anything more than $350 under many plans is considered to be a high-cost therapy. Two other definitions that we need to cover because they'll be discussed today: copay assistance programs and patient assistance programs. So copay assistance programs are typically programs that beneficiaries get that are funded by third-party organizations to assist patients with high out-of-pocket costs for their medications. So these are intended for individuals who have insurance but have high out-of-pocket costs. Patient assistance programs are typically funded by drug manufacturers directly, and they provide eligible patients with access to brand name medications at little to no cost to themselves. They're intended for people who are underinsured or uninsured. Thank you. Now we want to dive into the survey a little bit. And so we're going to turn to the exact substance of the 2023 survey. To ensure that we had the right respondents for the survey, we had some qualifying questions to require that the individual completing the survey be at least moderately familiar with their employer's health benefit offering. However, nearly 60% classified themselves as highly familiar. So we know that they are moderately familiar, but most who responded to this are highly familiar with their healthcare plans. And so we thought that was important to make sure that we had the right people answering our survey. I'm sorry. We had more than 180 respondents to our survey. And so this is a list of the types of respondent that we received for our survey. And you can see it's a broad base of people in the HR space. So that's great. And then we also got folks from outside of that space. So some nonprofit manufacturing industries, professional service consulting, finance, retail, wholesale, education, construction. So we have a broad base of employers here as well. So we first asked the question was to get general perceptions of copay assistance programs. And so copay accumulator programs have really proliferated. And so we wanted to make sure that we understood what people thought about these programs and understood these programs. And so nearly half of the respondents do not have copay accumulator programs in their plans. So that's great. But almost a quarter do have copay accumulators, and then a quarter were unsure whether or not they did. More than half of the respondents feel that manufacturers use coupons and copay assistance to steer patients towards high-cost drugs. And nearly every respondent feels that without copay assistance programs, some employees in their organization would not be able to afford their medication. So we found some good knowledge about copay assistance programs and copay accumulator programs. And so these are the survey questions that I just referred to. We asked, in your opinion, do manufacturers use copay coupons and copay assistance to steer patients towards high-cost drugs? The general prevalence, 57%, do believe that this is happening. Some don't believe that, and others are unaware. The second question that we asked in this topic was, without manufacturer assistance, copay assistance programs, would employees in the organization not be able to afford their medications? And at least 35% believe that they would not be able to afford their medications in this circumstance. My first question that I want to go to our experts is, does any of this data on responses to copay accumulators and their purpose surprise you? Start with Amy.
Thanks, Gavin. And before I begin, just a huge thank you to AIMD Alliance, the Alliance for Patient Access, and HR.com for hosting this webinar. The topic is critically important. Not necessarily surprising, but disturbing to me is the 25% that do not know if their plan has a copay accumulator program. Now, we know that often the term copay accumulator is not used in plans, that those words are often masked by other words, but I do believe it behooves employers to ask questions to better understand what's included, what's not included in the plan, so that they understand if their plan is really serving the needs of their employees. I'm not surprised by the 6 out of 10 respondents who indicated that they think coupons and copay assistance steer patients toward high-cost drugs. That is a belief we at the PAN Foundation have heard for years, honestly. But the reality, in my opinion, is that the patients need access to the medications that their healthcare providers have prescribed, presumably the medications that the provider is deemed to be the most effective. And also the reality is that in many cases, there are no generic equivalents to these branded medications.
Thank you, Amy, for that. I'd also like to get Cheryl's perspective on this question. Cheryl, you work directly with insurers and employers on this issue, so I'd love to hear your perspective on this data.
Sure. I'm not surprised at all by the numbers, and I'm surprised that the 25% of those that don't know isn't higher, to be honest with you. And for my employer members, the good news is we are finding that less of them are using the copay assistance programs from what they did maybe 5 to 10 years ago. As you said, Gavin, this whole area is like a game of whack-a-mole. With PBMs trying to save employers money so they don't have to change the way they're doing business today. And there could be many other things that they could do to reduce employer costs. Alternative funding programs, which I know we will talk about, is probably not the best option. But it's my hope that PBM report legislation will happen soon and help modify the way things are being done.
Thank you, Cheryl, for that perspective. I think it's really important to level set kind of what employers who are making the decisions actually do know. So thank you for that. So now we want to take a look at employers' use of alternative funding programs. And so, Kim, we would like you to explain for the group and level set for us, what are alternative funding programs?
Happy to. As Ashira did a great job in summarizing them in her introduction. So AfPs, known as alternative funding programs, they're programs designed by for-profit companies or vendors, and they specifically target self-funded plans. They do this because self-funded plans are not subject to many of the requirements that a fully funded or small group plan are subject to. So their goal here is to carve out or exclude. And sometimes they take a different path in this by automatically denying prior authorization. But they do this with the goal of having patients appear to be uninsured. And if a patient is uninsured, then they technically, if they're truly uninsured, are potentially eligible, and the word potentially is important, for a manufacturer patient assistance program, which provides coverage for the drug. Whether or not a patient's or an employee's drug is carved out, unfortunately, the patient doesn't know this typically until they go to fill a script or go to get their cancer treatment working with a center or another disease group. So at that point, the patient learns and is told, I'm sorry, your drug is not covered, and you're going to have to work with us, the alternative funding vendor, to apply for a patient assistance program. If all goes well, and we'll dive into more details later, best case scenario, the patient does qualify ultimately, but with significant delays. And unfortunately, many patients will not qualify. And again, we'll discuss this in more detail later because there are eligibility requirements, including income. And when that happens, these patients really are left in limbo and at the whim of their employer on whether or not they do get coverage. Now, in return for these services, an employer pays these vendors a fee. Typically, it's 25 to 30% of the cost savings achieved, if any, and possibly also a monthly fee. So this is done. This is not done out of the goodness of the heart for these vendors, but in order to make a profit. So while employers sign up with these vendors for this thinking they're going to save tremendous money, we'll learn more that in reality, perhaps they're really not saving as much as they thought they would be.
Thanks, Kim. Sounds complicated, and I know that it is, but I appreciate you kind of explaining it for all of us, and so that people can understand it and recognize these programs when they're offered these programs, but also when they're applied to these programs. We talked a little bit about kind of the awareness around copay accumulators, because that's kind of the first step in this. We also asked a survey questions about alternative funding programs and have people heard of alternative funding programs. More than 50% had not heard of these programs. Cheryl, I want to turn to you. You've done a lot of purchaser-driven research on this topic, and you work to inform employers of ways to manage some of these higher cost specialty medications. Does it surprise you that more than half the respondents have never heard of these programs?
Well, not at all. And, I always say, if you're not part of an employer coalition, how do you know how to benchmark what other employers are doing, what's working, what's not working? So the vast majority of employers are relying maybe on their broker or their benefits consultant or their PBM or their insurance carrier to tell them what to do. And oftentimes they may not be talking about this. And I've heard a handful of times where employers have these programs and they don't even know about it. And they find out when the employee notifies them that something is odd. So the numbers don't surprise me at all. And, we've been talking to our members about copay accumulator and maximizer programs for years. I think alternative funding programs, honestly, are more egregious because of how they're taking money away from patients that are indigent or underserved and really, really need these programs. So I have just, felt since the beginning of hearing about this a number of years ago that it's really unethical. We've got all of the things, and I know we'll talk later about some of the patient impacts, but you've got this patient now who, may need to be on a medication sooner than later, and they've got delays. They're very confused about what just happened, that they've been turned down. There's a myriad of other challenges, but I'm not surprised by the numbers, and I am hoping that we will see more employers not only being aware of them, but understand the real implications in the very near future.
Cheryl, staying with you briefly, are you seeing trends from your members, your employer members, towards adoption or not adoption of these programs?
I think when they first came out, there was more adoption because I'm still confused by them. I'm in awe of you guys talking about them. and trying to separate them from the copay accumulator and maximizers, yet those are still tied into it. I think for our employers, helping them understand that once the patient assistance program is exhausted, that patient is responsible for the total payment until that deductible is met. And we know that that patient might abandon therapy and that impacts outcomes. We're just trying to get employers to understand what they are and ask the right questions of their PBMs. Again, you know, there's the whole dark underbelly. A handful of my members are doing them. They don't want me to talk about them doing them, and their senior leadership is requiring that they do them because they don't have any other levers to pull. And I'm going to say that again, they don't have any other levers to pull. So if we're going to have these types of programs in the market and an employer's hands are tied because costs across the marketplace, not just the cost of the drug, but across the marketplace. And if we look at how much more, I think one of you might have said something, but specialty drugs, PBMs and intermediaries are adding 30 to 50% onto the cost of already high specialty drugs. And I won't even talk about the cell and gene therapy pipeline coming. But if your leadership demands it and you're embarrassed by it, that's not a good situation. So I think education for organizations like ours has to be key, and accountability for the PBM has to be key.
Thank you for that answer and for that perspective. It's really insightful. One of the words I think you used was nefarious. And I will say, you know, when you talk about accumulators and maximizers and now alternative funding programs, it is all of the same tree, and it is becoming more nefarious. This is another example where if you participate in these programs, you require your employee, your beneficiary, to step outside of their health insurance in order to get coverage for their medications. And so thank you for that answer. I want to move on to the next question that we asked in our slide. And the question we asked here was, is enrolling employees who are enrolled in your healthcare plan into a charitable assistance program for underinsured and uninsured individuals an effective way to reduce health plan costs on prescription drugs? Again, this was a divided question. Some 34% didn't know. 31% thought, no, this was not an effective way to do this. And 35% thought that, yes, this was an effective way to do this. So we know that employers try to save money by utilizing alternative funding programs and steering patients to free drug programs or charitable assistance programs. And according to the survey, there's a split among HR professionals on whether this is effective. Amy, I'd like to turn to you as someone who has an assistance program, and would like to talk. Could you explain the services that your organization provides to patients and how insurance pushing patients with high cost specialty medications into charitable programs can affect that work?
Yeah, absolutely. And the services provided by an independent charitable foundation like the PAN Foundation is a little different than those provided by manufacturer patient assistance programs. At PAN, we provide financial assistance to cover the out-of-pocket costs for prescribed medications, which are the copays, the deductibles, the coinsurance, and this is for people who are underinsured. People who have health insurance. We're the payer of last resort, and that is a really important point to make. So the primary insurer, in this case, it's the employer-sponsored health plan, comes in first, typically to pick up the out-of-pocket costs. And in order for PAN to provide coverage for costs to help the individual, that primary insurer must cover the medication. We also have income guidelines. So the people that we are supporting, the income guidelines are, they have to fall at or below 400 or 500% of the federal poverty level. Now, we provide financial assistance today across about 70 different disease areas. And in each of our disease areas, we have a broad formulary of covered medications, and they are all FDA approved brand and generic medications. So, for example, if someone comes to us and they have hemophilia and they're looking for assistance, they need to be, according to our guidelines, they need to be treated for hemophilia. They're residing and receiving treatment in the United States or territories. They have health insurance and they are prescribed a medication that's on our formulary, and they have income at or below 500% of the federal poverty level. Now, what's important for us as we enroll patients, and we're providing assistance for hundreds of thousands of patients every single year, it is typically the patient, in this case, the employee, who would be self-enrolling in our programs, either by calling our contact center or going online to enroll. Providers and pharmacies can also enroll on behalf of the patient, but alternative funding vendors are not eligible to enroll patients. So from our perspective, there's a few critical issues. One is that simply employees are paying premiums into their employer-sponsored health plans and are expecting that they will have access to the medications they need, the medications that have been prescribed by their healthcare providers. You know, none of us ask to live with a serious health condition. And in our opinion, the employer health plan has an obligation not to arbitrarily carve out certain or all specialty medications. We see this honestly as a discriminatory practice. It targets individuals who are living with serious chronic conditions. Furthermore, the safety net that exists today, both the manufacturer patient assistance programs and those provided by organizations like PAN, this safety net has limited resources. We know at PAN, because we have wait lists, that the need for the assistance far outweighs our ability to provide assistance. And this is not only true for PAN, but it's true for organizations like Cancer Care. The people that we're helping are truly the most vulnerable. We hear every day that people make decisions, unfortunate trade-offs between being able to afford their medications or being able to put food on their tables. And we know, looking at our data, we're serving the most vulnerable, those between 150 and 300% of the federal poverty level. So these are the individuals that we have to preserve our safety net for.
Thanks, Amy. And so that's a really good kind of outline of the impact that the use of alternative funding programs will have on patient assistance programs and charitable programs. And so preventing them from serving the population they're intended to serve. And so I appreciate that. Kim, I'd like to turn to you and understand a little bit about, so if 35% of employers think that this is a good way to save money, so that's kind of their perspective. From the perspective of a patient, what can you talk a little bit about the impact that these programs have on patient access and patient care?
Yeah, of course. The patient here, we've got to remember that the patient and their need, and as Amy quite eloquently stated, these patients have serious, often life-threatening conditions. People do not pay their premiums and other healthcare costs to manage and get a prescription for amoxicillin. They're thankful for that and having that healthcare to help cover that. However, really people have and are willing to sacrifice the cost of healthcare for what if and when something serious comes along: cancer, hemophilia, MS, cystic fibrosis, and other serious diseases. So for these patients, it's not an option. It's not a luxury. They need these medications to manage a life-threatening or to preserve their life. So some of the harms that come in from these alternative funding programs, first and foremost, as I mentioned earlier, everybody, whether or not you're ultimately approved for a patient assistance program or not, everybody subject to an alternative funding program experiences serious delays through the application process, learning if they were approved or not, if it gets sent back to the employer. And for these types of conditions that specialty drugs treat, time is of the essence, and we do not have time to wait 1, 2, 3 months in order to try to get people access to those medications. In addition, a lot of these patient assistance programs may not have sufficient funds to cover an entire course of treatment. And I think Cheryl referenced this before. So you may ultimately qualify for a PAP, but then the PAP runs out in the middle of your course of your treatment. And then where do you go? How do you get the rest of that treatment? Also, alternative funding programs are influencing, unfortunately, providers' treatment decisions. They're getting in the middle of that patient-provider shared decision-making process, because perhaps a patient assistance program is available for one treatment, but it's not the treatment that that prescriber, that clinician wants that patient on. And it really makes it challenging to get the right medication to the right patient at the essential and right time. Another very large and very real barrier are the income requirements. And Amy referenced them with regard to the PAN Foundation, as Cancer Care and all other charitable organizations have, but also patient assistance programs, manufacturer patient assistance programs also have income eligibility requirements. So some patients may qualify for a patient assistance program. And if they do, and as I referenced before, they will get their medication or part of it and all the other harms that I just mentioned. But those that do not qualify because they do earn more than that income eligibility limit that the patient assistance program has, they are left in limbo. Then what happens? Their employer can or cannot agree to override the exclusion or carve out as a medical necessity, and then go down that path so they can get their medication. Again, keep in mind all the delays that have happened up to that point. Or they can also, if they took that prior authorization route, and let me explain very quickly, some plans using alternative funding have learned that their stop loss was impacted because those providing stop loss coverage were saying, well, wait a minute, we have increased hospitalizations, we have all these other things because you're not covering necessary medications for serious disease. So the plans at that point, kind of some of them shifted a little bit and said, okay, we're not going to outright exclude, because that way our stop loss coverage is impacted. So instead, we're just going to automatically deny prior authorization when any of these specialty drugs come across and want to be filled. So I just wanted to explain that a little bit. So it can either be, the exclusion can either be overridden as a medical necessity, or that automatically denied prior auth can subsequently be approved. But again, it doesn't have to be. And later I'll share some examples of when that happens, or if now is good, I can share them now. In one example, it's kind of a typical case of an AfP. Patient didn't know the drug was excluded. They had cancer. This is a major cancer center working with patients, both of these examples. They were informed when they went to the cancer center and started their the process for completing their application with the cancer center, getting insurance coverage and all those things. And they were informed they do not have coverage for their chemotherapy. We're very sorry. We understand you have cancer, but we don't cover chemotherapy. You'll have to work with us, this vendor, and we will try to find you an alternate source of coverage for that. Ultimately, this is as positive a case as it can be with alternative funding programs. Ultimately, this patient did qualify. They met the income requirements and the other requirements of the patient assistance program, and they got their medication. Unfortunately, over a month passed before that medication was available to the patient. And in the second scenario from the same major cancer center, the patient got their coverage through a union. And I do want to be sure to mention that many unions, like many self-funded employers, also use alternative funding programs. So keep that in mind when we say employer, that also encompasses unions. So in this case, the person was prescribed a take-home medication, FDA standard of care medication, and importantly, the only therapy available for this type of diagnosis. This patient was informed, I'm sorry, we don't cover any specialty drugs. We don't cover your cancer treatment here. We do approve your prior authorization. And this was unique, and this shows the smoke and mirrors of this. When the hospital submitted forms, they approved the prior auth, but then later said, oh, but that is just so that we know it's medically appropriate. The drug is still carved out, even though the prior auth is approved, but the drug is still carved and we're not covering it. So the patient tried and they did not meet the income eligibility requirements for a patient assistance program for this drug. And again, this was the only therapy for this diagnosis. Over a month later, the patient is still in the hospital, the center, and the patient is still today trying to work through to get this person's treatment. To date, they have not been able to get it. So unfortunately, these are very real life situations, and it's happening every day to real people.
Thanks, Kim. I appreciate the overview, but really the kind of tangible examples of the impact that it's having on beneficiaries is really important and notable. So thank you for sharing those stories. Amy, I have a question for you. So charitable programs like the one that your organization operates aim to help ease financial burden to ensure equitable access to affordable and appropriate care. What other burdens get placed on caregivers or the family structure due to the economic impact of the use of alternative funding programs?
Yeah, no, thanks for that question. And we see every day how important this assistance is for those who are seriously ill and need access to their prescribed medications. We do annual surveys of our patients, and we hear time and time again that without assistance, they simply are walking away from the pharmacy counter. They are doing things like trying to make their medications last longer. They're stretching it out. They're cutting pills in half. And then after receiving assistance, they're doing less of that. And that's a good thing. But let's take, for example, a patient who is living with cancer. It resembles the case scenarios that Kim just shared, who may find themselves in the middle of an AfPA scheme, and they may need to self-pay, or they're told that they need to self-pay, for example, to get access to their medication. What happens then? Well, they may choose not to self-pay because they simply can't afford their out-of-pocket costs. So when they decide they can't self-pay, what happens? Well, imagine the negative impact on their health. They don't have access to their medications, and there's tremendous negative economic impact to the healthcare system that may result, because over time they may find themselves visiting their healthcare providers more. They may find themselves in the emergency rooms, ultimately hospital stays. Imagine the negative impact as well. This patient is an employee, so that employee can't, contribute as positively to the employee workforce because they are ill. If they find ways to self-pay, what happens? Well, unfortunately, they're likely to make unfortunate trade-offs to be able to afford their medications. Something else has to give. And this is what we hear all the time. If I pay my medications, I may have to put my rent off. I can't pay my utilities. I can't put as much food on my table as I would like to. More credit card debt, more medical debt. They're dipping into savings that they shouldn't be dipping in. So this, we hear all the time, this not only impacts the patient, but it impacts their family, and it impacts the quality of their life. And, I always say, when you are living with a serious illness, you should be solely focused on getting better, managing your health. You don't want to be burdened with having that financial burden, and which just increases the financial toxicity that you're going to experience and your family is going to experience.
Thank you, Amy. The impact is broad and wide, and so we appreciate kind of hearing that from our experts here. I want to turn, Kim, to you for a question here on our next topic. We want to continue on the path of kind of the uninsured patient trying to access their medications. One of the things that we've heard is that these plans talk about, or they propose, of importing medications from Canada or Europe for these patients. We've got one of the survey questions on that topic showed that 60% of respondents stated that would be an ethical method of reducing costs. Can you talk about the implications of drug importation to try to meet these insured patients' costs who are being asked to step out of their insurance for their specialty medications?
Yes, it's a great question, and it's very real. And in fact, many of these plans will state right on their forms that we may source your drug from overseas. And sometimes they say if that's the case, it may take longer, etc. Well, this is a very big problem, both for patient safety, and that has been, recognized by the FDA, and also really for the employers doing this, and working with the vendors and illegally importing. So the FDA does not permit new unapproved drugs or misbranded drugs from being imported from overseas. It is illegal importation, and I'm amazed actually that these plans actually, many of them state on the bottom that they do this. Um, the FDA actually back in March of 2023 of this year issued a warning letter to an alternative funding vendor who was doing exactly this. And let me step back for 1 second. Sometimes if a patient assistance program is not available, you say, well, why would they go overseas? A patient assistance program may not be available for that drug that's needed, or maybe something they are able to get it cheaper overseas. And I know you prefaced this question here on the survey on Canada and Europe, but let's be clear. Some of the drugs, even that are currently in Canada or Europe, may have originated from China, India, and other places. So there's real safety risks in that in and of itself. So the FDA issued a warning letter to a major alternative funding vendor, and in fact said, you must stop this practice. What you are doing is illegal. You are acting as a broker between foreign pharmacies in order to bring in drugs for this employer's patients. That is illegal. You must stop doing that. It's interesting also that the warning letter itself, I think, really got to the heart of the matter here. And it said one thing that was particularly concerning about this scheme is that employees, when they have employer sponsored health insurance, they trust that health insurance. They trust their employer has their best interest in mind, and that their safety, is foremost. And their employer would never do anything that would potentially place the employee at risk. And this FDA warning letter specifically pointed out that the employees do trust their employers in this, which makes it especially dangerous, because these patients don't even think that there's a possibility that these drugs could be unsafe, which is very disturbing and very harmful. So they don't even question or challenge. And that trust that is broken, in addition to the potential harm caused to the employee, is a serious breach, really, of that fiduciary duty, which I know we'll talk about more later. But that breach of fiduciary duty between an employer and their employee. I will say that the vendor who got the warning letter sent a letter to their clients stating that FDA is all wrong. What we're doing is perfectly legal. It's personal importation, and we're allowed to do that. But this is not personal importation. This is the vendor working with the employer overseas to contract with these pharmacies to bring in these drugs. That is not a patient personally going or seeking a drug from elsewhere. And there are provisions with the FDA. The FDA is looking into, allowing certain importation, so states can apply for a way to import drugs from certain countries, from Canada and certain countries. But none of those have been approved to date. A state must submit a plan to the FDA. It has to be approved. None of those have been approved. So this importation is in fact illegal and unsafe for the many reasons that I stated.
Thanks, Kim. Cheryl, I'd like to ask a question for you. And so some of what we've heard about these programs is they're not health insurance programs. They are third-party vendors. And so they're subject to lesser restrictions or requirements. One of the concerns that's been raised on this has to do with the Consolidated Appropriations Act, CAA. Can you explain briefly how employers may need to consider this legislative requirement as a compliance concern when working with these programs?
Thank you. Obviously, the Consolidated Appropriations Act is something we're following closely. And of course, it is compliance with employers as fiduciaries, and no one else can be fiduciary, just the employees, or excuse me, employers. That means that employers have an obligation by the Department of Labor and legislation stating that they must offer the best benefits at the best price for their beneficiaries. And it's interesting because in the coalition world, or in the employer coalition world, whether we're fully insured or self-insured, we're the real payers of healthcare. It's not the carriers, it's not the PBMs, and yet we have little to no say about the cost or price of medical or pharmacy benefits. And it's interesting that with the Consolidated Appropriations Act, for the first time, employers are truly on the hook for benefits to be cost effective. Yet the loophole of alternative payment programs or funding programs doesn't make sense in this environment, even though it appears that we're saving money. It's pulling funding from people who can't afford their medications. And as you guys have said previously, to those who are most vulnerable. So we're telling our employer members that they should first and foremost, if they want to look at these programs, get legal advice, because there are issues concerning ERISA and IRS compliance and the use of funds involving employee premiums to pay for AFP administrative expenses. This could actually constitute a breach of fiduciary responsibility under ERISA. A lot of people aren't talking about that. We're also recommending our employer members talk to their internal people, and that might be people in employee relations. How could this impact employees? Could it come back and bite us for doing it? Talk to employees and even risk reduction representatives during the decision-making process if AFPs are right. And even if AFPs limit obtaining AFP funding to lower income participants, plan benefits may become skewed toward highly compensated employees that can lead to tax code violations without taxation of these employees. This is another issue that I'm still trying to put my arms around. And we also recommend that employers do a cost savings analysis. That should include the disclosed administration fees, as well as non-disclosed factors like loss of rebates, patient cost share contributions, changes in network discounts based on sales volumes, and fees related to communication of plan changes. We're encouraging our members to speak to each other, especially for those that might have long-term experience, whether it's perceived good or not good, and what their learnings were. A lot of my large and jumbo employers are not using AFPs, and it was interesting at the beginning for me to hear you say that it's really targeted to mid-size employers, and that is true. They're the ones that are struggling the most. They don't have the leverage that the large and jumbo have. And there are recent and pending lawsuits going on right now related to these programs and vendors, and the marketplace continues to shift. So we might think that they're out there and they're still legal-ish, and then that could change very quickly. And we also need to be paying attention to what's going on with PBM legislation as well.
Thanks, Cheryl. That's really helpful. What I think I take away from that is, and it was a survey question that was asked, was, do employer compliance departments have concerns about these plans? And the survey result came back that 9% have expressed concerns about these use of alternative funding programs. But I think that, Cheryl, you just laid out very clearly kind of some of the concerns that they need to be considering. So I think as people are looking at these programs, making sure that compliance is looped in early and often so that they can analyze them. Of the folks that did have concerns, there was employee treatment compliance concerns, but also federal health laws were concerned. And so those are the ones that I think really people need to be aware of. And so thank you for that. Our next set of questions is going to be about really, we understand that healthcare costs are really a really important issue for employers. They have to manage them very carefully, and they want to ensure that they're doing the best they can by their employees and their families and their beneficiaries, yet at the same time making sure that they're making smart decisions. And so we have to appreciate that employers have costs they're trying to manage. It's a genuine concern. I'd like to ask the panelists here, and we'll start with you, Amy. If they're looking for for something different than an alternative funding program to help control costs, do we have recommendations that they can consider? So we'll go through all the panelists, but Amy, if you have any recommendations, that would be great.
Yeah, as Cheryl alluded to, it's hard to identify where the employers can save costs, and certainly we all recognize that healthcare costs are increasing, prescription costs are increasing. So this is a real issue for all employers, but I think we would all agree as well that saving dollars through alternative funding program schemes is not the way to lower costs if you're an employer. I, encourage employers to really think about the negative impact that delays in care, inability to access care will have on the health of their own employees, and in turn on the health of their organizations. Specialty medications like generic medications should be deemed an essential health benefit by employer-sponsored health plans. I pay into the plan that's offered by the PAN Foundation. When I pay my premiums, I expect to have access to the medications I may need today or tomorrow when potentially I am diagnosed with a chronic condition. And I hope that doesn't happen, but that the reality is that we need to think about that. So, as leaders in our own organizations, we have to ask these questions. I know, as an employee, when we were thinking about our health plans at PAN, I raised my hand and said, do these health plans have AFPs in place? Are they carving out specialty medications? Are they referring employees and patients to outside vendors that are not insurance companies? Fortunately, we didn't have that in place, but I think we all have an obligation to ask those questions.
Thank you, Amy. So Cheryl, you're speaking directly with employers on these issues. What alternatives or what other options do you propose or provide them that they can help control costs while not utilizing programs like this that require third-party vendors and the impacts that those can have? I think you're on mute, Cheryl.
For years, we've been talking to employers about unbundling their PBM contracts and putting back the pieces together that make sense. And so getting to net cost, auditing your plan, optimizing the PBM contract so it benefits the employer minimally equally to the PBM, because right now most of the contracts only benefit the PBM. I think, getting, as we call, the crappy drugs off of formula. So there's a lot of things that we can do to reduce costs in other ways. And then we as an employer community really need to look at these programs that were developed, as I said earlier, because PBMs didn't want to change the way they did business. They've been creative about implementing programs that are not always in alignment with the right thing to do. So, there's a lot an employer can do today.
So Kim, before I ask you the same question, I'll open it up to the broader audience for anybody who's listening today, who's joined us. Thank you. We have time for questions. So if people want to drop those into the Q&A, we will happily try to answer those questions. Kim, I will leave this question to you about kind of what else can employers do to control costs that are short of taking these steps, but also any broader thoughts that you want this audience to understand about these programs, the impact of these programs, and what's happening.
The best way to reduce costs and for employers to save money is to make sure that the employee gets the most appropriate treatment for whatever condition they have. Because the highest costs in our healthcare system, while we're focusing on prescription drugs here, and alternative funding is focusing on prescription drugs, and yes, specialty drugs are expensive. They're made to treat very serious conditions, and a lot goes into making those drugs through the clinical trial process, etc. But the highest costs in our healthcare system are really when people are hospitalized and need all that additional care. So by getting the patient the right medication at the time at the right time and in a timely manner, that actually saves employers money. In addition to that, let's really keep in mind, if we're going to carve out medications to treat serious conditions, employees are going to question, why am I paying these premiums? Again, it is not the $10 amoxicillin, not to minimize. $10 can be, significant amount of money for people. However, that is not why people have insurance. We, as a country, we rely on the employer-sponsored healthcare system. This turns that entire system on its head if people do not have access to medications that they need to save their lives. Again, let's not forget that these PAP programs are there for people who don't have alternatives. And by rating these programs for those that really do have coverage, doesn't help anybody. Employers as well, when word gets out that somebody in your company has cancer or their child has cystic fibrosis and the insurance isn't covering it, don't think that that's not going to spread around. You are not going to get the employees, and your employees are the key to a successful organization. You are not going to maintain or get new employees to join your organization and help you do what you do and what you specialize in as a company.
Thanks, Kim. Amy, I have one final question for you. Kim gave us some examples, some very tangible examples of the impact that's happening on patients. Cheryl helped us understand what employers are thinking about and trying to understand. I want to know from you, your experience with your charitable foundation of these programs. It's very 30,000 foot. They exist. We know they exist. They're being sold. People are buying them. But are they really having an impact? And have you seen them in your program?
Yeah, thanks for asking that. And we have, unfortunately, this year, when we realized how quickly the use of AFPs was expanding amongst employers, we did some sleuthing on the back end at the PAN Foundation, and unfortunately found one vendor who had over a couple of months enrolled 600 to 800 patients in our programs. As I mentioned earlier, alternative funding vendors are not authorized to enroll patients into our programs. We had to spend precious resources at PAN to disenroll these individuals. We proactively reached out to them as well, just to let them know about the services we provide and to encourage them to apply on their own if they thought that they would be eligible for assistance. But it was unfortunate that we had to do all of that. Most importantly, if we hadn't, 600 to 800 patients who truly qualify for assistance may not have been able to receive assistance because we would have provided resources to individuals who in the first place should have been covered by their health plans.
Thanks for that, Amy. In addition to obviously potentially ineligible people draining down charitable funds, the pressure on your organization to try to identify and remedy that is really significant. So we're coming up at the top of the hour. I really just want to thank everybody who participated today. I want to thank Ashira and Aimed Alliance for helping coordinate this webinar, for their partnership in this survey and their partnership on this important issue. We have links in the slide deck that will be available that lead to resources on this topic. We would encourage everybody to go look at these resources as they can. These are from our hosts, and we also have resources from our partner organization. So Cancer Care, Midwest Business Group, and PAN Foundation all have resources on these issues and on their own expertise. And so we would encourage everybody to look to these issues. With that, I will say thank you again. I'm going to turn it back to hr.com.
Thank you, Gavin. This concludes our webcast today. I would like to thank our presenters, as well as all of you for joining us. If you joined late and would like to view the webcast again, the recording and slides will be available on hr.com on our archived webcast page. Please take a few moments and fill out the webcast survey that will open on your screen. Your feedback is very important to us. This concludes our webcast. Enjoy the rest of your day.